meeting. Thank you very much, Manu.
Thank you, Andy. Thank you, Naomi.
I've got the honour of introducing our next speaker is Dr. Brinder Mahon, who's a consultant radiologist in Birmingham and really runs the endoscopic ultrasound in the QE, which is a massive service in the country. He's probably topping over 1,000 endoscopic ultrasounds per year. And at the time of doing all that, also seems to manage all the MRI referrals for the cysts that he's going to be talking about to you today. He's been a previous leader of our UK EUS department, and also with all this, he's also been honoured for the amount of charity work he does. And despite everything, he gives the most sensible opinion, and also managed to mentor me at the beginning of my career. So, Brinder, thank you ever so much for being with us today, and we really look forward to your talk.
Hi, good morning, Andy. It's a really kind welcome, and it's really wonderful to join everyone. It's a real shame that we're not together, as Manu was saying, particularly because I wanted to rib Manu on a couple of points on the panel, as I like to do. The pancreatic pseudocysts is really interesting talk, but I of course won't ask any questions about it at the moment. But I'll get through this very, very exciting talk now on pancreatic cystic lesions, which I know that you can't wait to hear about. It's an area which can prove really frustrating to MDTs, to clinicians, to think, oh my God, it's another pancreatic cyst, yada, yada, yada. What we're going to, let's do the usual, let's watch it, let's do something, or let's do nothing. So there's a huge variance of what people do. People get bored, people get excited, and it varies. But what I'll try and do is try and give you some of the lessons we've learned, some of the mistakes that we've learned over time, and see where we're going next. Unfortunately, I've got quite a few slides, but I thought I just wanted to give you a brief overview really quickly on what pancreatic cysts are, look at the high-risk signs, look at some common scenarios, and what we might have done better. We'll compare some of the cyst guidelines out there, and of course, as I said, some further developments. Okay, so as I was saying, this is not a small problem. The number of pancreatic cysts, particularly in this series, as identified back from Japan, showed that there was almost 27% of patients at autopsies had pancreatic cysts. And this MRI series demonstrated at least 14% of consecutive MRIs. So the problem is big, and as our imaging gets better, we're going to pick up more. However, how many of these cysts are actually worrisome? Well, actually, this is really good data back from 2014 from the Americans, which showed that actually only 2 to 5% ever become pancreatic cancer. But these are not necessarily people who die from pancreatic cystic cancer. People who die roughly are sitting below the 2% mark. Okay, so which cysts do I need to worry about? What cysts are there? Well, number of cysts, as you well know. The cysts that we really want to worry about, of course, are the mucinous cyst adenomas or the Ipmns. They make up roughly about between 20 to 40% of mucinous cyst adenomas and around 40% of Ipmns. If you go back 20 years or 25 years, it used to be in many textbooks that pseudocysts make up 70% of all cysts, but that has long since reversed, and actually pseudocysts only make up around 20% of pancreatic cysts. Very quickly to demonstrate or just to show you what they might look like, serous cyst adenomas can be microcystic or macrocystic. Are essentially benign, contain glycogen, and of key have low amylase and a low CEA level, less than 5 usually. Mucinous cyst adenomas, sorry, here's some CT examples of and an US example of microcystic disease. If I can show you particularly on the lower CT image, you can see when the microcysts become very dense, actually it can become very difficult sometimes, particularly if the cyst is small, to really understand that this is a cystic lesion. And on EUS, the fine septations are much more easily understood. If someone can help me just shift the slide forward for some reason. There we go. Fantastic. Mucinous cyst adenomas. are pre-malignant or malignant, contain mucin, ovarian-like stroma, a low amylase, but the key to diagnosis is usually a higher CEA, and usually it's around 200. We'll talk about that in a moment. Here's some examples. They can be, the difficulty with these, they can be very simple looking and look very benign on CT particularly. They can become very large and contain very many septations and therefore look complex, but that complexity doesn't necessarily equate to malignancy, because when you see this complexity, particularly on AUS, you can see that these septations are actually very thin-walled and fine. And what we're really looking for are those early signs of malignancy, which include nodules, solid tissue, irregularities of those septations, and particularly masses around or pancreatic ductal distension distal to the cyst. Ipmns classically are formed within the duct, a dilated duct, a 2% lifetime per year risk of turning malignant, or 20 to 40% lifetime risk. They contain mucin, papillary projections, can contain a high amylase. However, the specificity of that is mixed between 50 and 60%, and the CEA is also variable. There's a couple of examples for you coming up. Here we go. You can see a classically dilated duct. This duct is approaching 10 millimeters. When the duct approaches 10 millimeters, your risk stratification goes up, increases, and particularly when you look at this case at the head of the pancreas, you can see there is some soft tissue around the duct, and particularly compressing the portal vein SAV junction, so early signs of cancer and malignancy, and in this case on AUS was confirmed to be adenocarcinoma. Within the duct on AUS, you can see these papillary projections. We know that when these nodules become greater than 5 millimeters, the risks start to increase, but particularly as they approach 10 millimeters and above. Classic sign on ERCP for main duct Ipmn is mucin extruding from the ampulla, as you can see, sometimes called the cyclops sign. Not an uncommon scenario is multifocal side branch Ipmn, and here's an MRCP image where you can see multiple cysts throughout the pancreas. Now, if this patient is not known to have VHL, this is 98% of the time likely to be multifocal side branch Ipmn. Often these cases actually don't need an EUS to diagnose this, but you might, of course, undertake an EUS if a cyst is increased in size or you see some higher risks on the MRCP image. So let's take a stock check. So out of all of the images in the cyst that I've shown you, is there anything that we can be definite on when we see an image about what type of cyst there is? Well, actually, there is so much crossover with the appearance of these cysts that it can be very difficult, both as a radiologist and as an endosonographer. It can actually be very tricky. The most likely diagnosis that you're going to get correct is that on an MRCP or an EUS that you see a lobulated cyst with a ductal connection and has duct-like projections is going to be a side branch Ipmn, the bottom left image. The main duct Ipmn can be confused with pancreatic ductal strictures and sludge within the duct, and is not necessarily pathognomonic when you see that on MRCP or CT, and a history is very important in those circumstances. The other cyst that you're most likely to get right from a morphological point of view is a microcystic cirrhosis adenoma. So that's the third image in the second row, where the cysts are less than 2 millimeters and they're very fine throughout. It's not a mixed picture where it's macro and micro, but it's all micro in appearance. These cysts are you're most often likely to get right on a morphological grounds. However, it is very helpful, certainly in our practice, to undergo have an EUS, have a look at these with more detail, take some cytology and histology, and do some fluid analysis, and we'll talk about more about that in a moment. Just a quick word about pseudocysts. Pseudocysts, of course, you'll all well understand, but really the image I want to show you is the ultrasound image on the left, which shows a pseudocyst with some debris, some necrosis within it, can be layered, and without a clear history or a biochemical understanding that somebody's had a raised acute amylase. In fact, it can be very easy to confuse the pseudocyst with one of the other cysts, and we'll see a case about that in a moment. Does MRI add anything? Well, many units do MRI regularly, just when this is being diagnosed. Our standard practice really is whether they've had an MRI or a CT is if the cyst is greater than 1 centimeter in a younger, fit patient, or more than 2 centimeters in an older, comorbid patient. We tend to go straight to EUS because we feel that we're going to get much more analysis at the first step and understand the type of follow-up that a patient might require. Okay, so let's see some examples in practice. This is not an uncommon presentation. A simple looking cyst in the pancreatic body measuring 2.7 centimeters. On CT you can see it doesn't have any complexity. On EUS, on the EUS image on the right, again very thin walled, no complexity, no pancreatic ductal distension around it. On EUS it was acellular at cytology. The CEA was 2,700 plus and had a low amylase. So a high CA above 200 gives us around 80% specificity that this is going to be a mucinous adenoma, and above 1,000, that specificity rises to above 90%. And in this case, we were very right that it was an MCA. However, there was no dysplasia. We know that CEA is not very helpful to understand the risk that a patient faces. However, in a patient who's young and fit, we know the lifetime risk is not insignificant, and so usually the right thing to offer is a resection. Another example, here we go. We've got a slightly more irregular looking cyst in the body of the pancreas. Could be microcystic or a mixed macro-microcystic picture. And in fact, it was on the US, and the CEA was rise 6 to 7. Amylase was low, so again, very likely to be an MCA. So good decision to go for a resection, but again, no dysplasia. So you could have argued in this patient who's around 75, you could have argued that he or she might have preferred surveillance. I like this case. This is a case that was referred to us of a 37-year-old male who's moderate drinker, but was referred to us for a pseudocyst drainage, had some epigastric pain, some gastric outlet obstruction. This is going back a few years. So when he came for a drainage, in fact, when I was consenting the patient, it became apparent that this patient had no history of pancreatitis. Both subacute clinical pancreatitis even at home, episodic pancreatic pain exacerbated at times. There was none of that. It was just a gradual increase of pain. So I decided, I thought I better better be safe and really analyze the fluid before I proceed. Even though this patient was a 37-year-old male who had some moderate history of drinking. And in fact, his CA came back as 6,400, and in fact his histology came back as mucinous adenocarcinoma. And 4 months later, you can see very irregular projections into his cyst, and in fact a metastasis you can see in segment 6, 7 posteriorly and peripherally, and patient died within 4 months. So on occasion, this disease can be a very aggressive disease, and it's important to not dive into a pseudocyst drainage unless there's a clear history. So cases we've got wrong and we might have done better on. Here you can see what looks like a fairly straightforward, I think it was a 2.7 centimeter cyst, unilocular, a CEA of just above 200, so 229. Amylase was unfortunately lipemic, and the point really to make here is it's not uncommon, and there's some great data published suggesting, particularly in a large European series, that approximately 25 to 30% of fluid analyses are incomplete for one reason or another, for various reasons. But in this case, this turned out to be a pseudocyst. And probably didn't need a resection like this patient underwent, but fortunately he was fine post-operatively. Here's another case. This case, middle-aged female with pain, no good history of pancreatitis. EUS, a slightly milky aspirate, CA amylase not possible again from our lab. There were some microphages on cytology. However, given we thought that this is very likely going to be a mucinous cyst adenoma, and given the size, given this was a female with no history of pancreatitis, we thought this patient should really undergo a resection, and it turned out to be another pseudocyst. Here is a nice case. You can see what looks like a regular looking mass in the head and unsnap process of the pancreas. There is some compression onto the portal vein SMV junction. Interestingly, this patient did not have any biliary distension, had some mild pancreatic ductal prominence. Patient underwent an EUS. I thought this was a microcystic lesion. Thought it was typical of SCA. The CEA supported that. Amylase was low. However, we detected certainly histologically some positive mucin. And given the doubt, I think there was some discussion had with the patient, and the patient felt at that time that she would prefer a resection, even though there'd been no change in imaging over 6 months, and turned out at resection to be a cirrhosis adenoma. So you can see some of the challenges we can have with some varying results from all of the tests that we might undertake in these cases. Here's another case. I like this case because this is actually not an uncommon scenario where you have patients referred with main duct Ipmn because of a very enlarged pancreatic duct. And on EUS, this patient had nodules. The nodules were measuring between 4 and 6 millimeters. There were at least 3 nodules. High amylase confirmed that this was pancreatic duct. CA was at 4,300. Had a total pancreatectomy. And what did we find on histology? We found that actually this patient had chronic pancreatitis and sludge balls within the pancreatic duct, which were adherent to the pancreatic duct wall. So a difficult case, but that rendered the patient, unfortunately, as a brittle diabetic. There's some quick pictures of some uncommon cysts. We've discovered one case over the last, I have to say, probably going back 20 years. One case that I've had that turned out to be hydatid in the pancreas. You can see the daughter cyst within the cyst on EUS in the top case, and the bottom case. It's not uncommon to see cystic neuroendocrine tumors, and actually it can be easy to confuse them with cirrhosis adenomas, and therefore that's why we always biopsy our cirrhosis adenomas. Okay, so what do we do? Well, there's a number of guidelines. You will have seen Sendai classification, the Fukako classification, the AGA in 2015, and more recently the Euro guidelines in 2018. What are the differences? Well, there are differences that they have evolved slowly. interestingly, there's been more caution, less caution, mixed caution in these. But let me just talk through one of the biggest challenges. One of the biggest challenges is well, what size of cyst really matters. Currently, the Euro guidelines are suggesting 4 centimeters or more is a more riskier cyst. The other area that is, of course, highlighted is anything that makes a cyst look complex. Nodules, mass, pancreatic ductal distension are all high risk factors. And so it's not as black and white sometimes as the pathway suggests. And the second question that's always put to us is, well, when is EUS appropriate? When is CT MRI appropriate? And you can see even in the guidelines, there's a mixture of when any of these tests are suggested. And in the latest guidelines in Euro 2018, the guys are really sitting on the fence where they've said, well, it's up to you to decide at any size cyst whether you want to do MRI or EUS, et cetera, et cetera. The important thing to note is if you look at the details of all of these guidelines and the evidence that they're based on, the majority of the evidence is 2C. So it's not surprising. It's not surprising. We really haven't got to a place where we've got real accuracy in our guidelines, and it's a number of factors which will help to make your decisions. On the one hand, some units are possibly resecting too many in a large surgical series. Over 20% of patients were found to have low-risk cysts, while 78% resected IPMNs do not harbor high-grade dysplasia or invasive adenocarcinoma. That was a study back in 2013 from Brugge's unit in Boston. On the other hand, we are likely missing some high-grade disease and invasive disease in this series from back in 2012, 287 resected cysts, of which 123 were side branch IPMN, 69 were Sendai negative, i.e. less than 3 centimeters, no mural nodules. However, up to 25% had malignancy on histology. So some mixed data out there. So where do we go next? Well, I think the area really we need to concentrate on is analysis and fluid analysis, where we're going. Cytology has had mixed results. We know it can be very specific, however, sensitivities are sitting around 50% in the best units, that is. More recently, the Moray forceps, which is a tiny set of forceps that go down a 19-gauge US needle, have had some promising results. There's some more data out which have got more mixed results. And basically what you're doing is grabbing a piece of the wall through your US needle and sending it for cytological, for histological analysis. However, the biopsy is literally less than 1 mil in volume, and so therefore can be tricky. But I think it's a good part of the armamentarium to have. CA results have been very variable and have been helpful. You can see that a cutoff in this study, which looked at a lot of analysis, mixed analysis, going back, obviously CA was one of our earliest markers going back to the early 2000s. And in this analysis, a cutoff above 1,000 starts to give us much higher specificities for mucinous cystic adenomas. However, between a classical cutoff around 200 and above, you can see the specificity really is much more mixed and reduces to between 70 and 80%. Cyst glucose is something that we certainly in our unit have been started to use really regularly. We've had a little bit of a go to get it through our labs and get them to understand, to make sure that we're doing it. However, this is a real high promise, very simple test in your grey tubes that you send off, but a high specificity for identifying high-grade dysplasia or adenocarcinoma in your MCNs and IPNs. So a real good step up. There's a number of markers which I'll fly through because I'm conscious of running out of time that show real promise. Now these are not necessarily easy to get results from because it depends on what your lab can provide for you and what your unit can do for you. But the point I really want to make is that we will become better as as a nation and worldwide, where we can diagnose these cysts in a much greater specificity. So PGE2 has shown promise. Various MUC5AC is showing some real good promise. Monoclonal antibodies, DAS1 is showing some real good promise. And methylated DNAs are showing some real good promise. So a number of these factors, what these studies are, what we haven't done yet is obviously start doing combination analysis of these and to see if we can get it to the next level. Okay, just a quick word for you EUS aficionados out there, just in case some of you might be doing confocal endomicroscopy. It's not something that I'm a fan of. It is a tiny endomicroscope that goes down your EUS scope. Some people really favor this, looking at the wall. However, again, the specificities are mixed, and even in the best hands, the best specificities are sitting around 75%. However, in most hands, they're sitting around 50%, which is really a toss-up. Okay, and just to summarize, pancreatic cysts are present in a quarter of patients, so we do need to get better risk stratification as to what we're going to be doing. The simple appearance of a cyst is not an indicator of simple etiology. Imaging specificity remains modest as there is considerable overlap. Only 2 pancreatic cysts, as I've described, a typical microcystic cirrhosis adenoma or a multifocal side branch Ipmn are really your 2 typical morphological appearances that you can be more confident about. And we're still some way off from perfecting the perfect cyst pathway until we have better developments of pancreatic cyst analysis, and particularly for diagnosing HUD and invasive adenocarcinoma. So thanks very much. I'll hand back over to Andy.
Thanks very much for that, Bryn. That was a really comprehensive overview of the pancreatic cystic lesions, which I think a lot of us find very difficult to manage in the MDT setting. I don't know how you guys find following up side branch Ipmn disease and that kind of never-ending follow-up imaging to then stop your follow-up and only find the odd few who then go on to develop aggressive disease when you stop following them up, or develop aggressive disease between follow-up scans, which sometimes makes me feel like we're beating our heads against a wall. I don't know what's your experience of that.
Yeah, no, I mean, it's a really good question, and you can see I've avoided answering that question in my slide, in my talk, because I didn't want to be black and white about what I say to you here, but I can just share with you our practice. Our practice, and it's changed over the years, particularly in the early 2000s, where the new disease in town, we were much more cautious about it. Then we went through a period of becoming less cautious about it and becoming bored about it, and now we're a bit more cautious about it again. So what are we currently doing? We're much more cautious with younger, fitter patients, is the bottom line. So we do a follow-up MRCP, particularly within 6 months in the first case, and then annual follow-up to make sure that it's stable in that period. And we do that for the next consecutive 3 years following that. If there's stability and the patient is approaching an older age and has other comorbidities, we start to relax our intervals.
And the other difficulty we have with MDT is lots and lots of incidental pancreatic cystic lesions, particularly in older comorbid patients getting sent in, and then deciding how best to manage those and whether there's an acceptable age or comorbid cutoff to not characterize or not follow up those sort of lesions.
Yeah, really good question, Naomi, again, as well. It's something that we've been grappling with our own MDT because we know that MDTs can be absolutely swamped with cysts. And so we haven't perfected getting these out of our MDT into and what we're hoping to do, and Keith, my surgical colleague, is on later in the next panel. What we're trying to do is to have this as a coordinated pathway outside the MDT, unless they show high risks. So any patient with comorbidities and not fit for a operation shouldn't really be hitting the MDT.
Yeah, it's difficult. We struggle in the same way, and have also talked about sort of taking these patients out into a separate forum almost, so that they don't swamp the rest of the HPB-MDT with the never-ending cystic lesions. I'm not sure there's a right answer. Thanks very much for your time and for your excellent talk. We'll release you.
Thank you, Naomi. Thank you, Andy.
Thank you so much.
Thank you for having me here.
Catch up soon, Bryn. Take care.
And our next speaker is Mr. Chris